Acute liver diseases and acute hepatic failure in dogs. For the general characteristics in acute versus chronic, in acute, there's rapid clinical signs due to a lack of time for hepatic regeneration. Chronic signs only appear after over 70% of liver function is lost. Specific signs are icterus, bilirubinemia, polyuria, polydipsia, and hepatic encephalopathy, and coagulopathy and ascites. Liver-associated ascites, the mechanisms are prehepatic, intrahepatic, and posthepatic. In the case of prehepatic, it can be portal vein obstruction. In the case of intrahepatic, it can be fibrosis or infiltration. In the case of posthepatic, it can be right-sided heart failure or hepatic vein obstruction. In the case of acute hepatic failure, the definition is when necrosis of over 70% of the liver parenchyma occurs. The clinical signs are icterus, depression, vomiting, and hepatic encephalopathy, which you will see head pressing and seizures. In the diagnosis and the lab tests, we can see increased ALT and increased AST and increased bilirubin. We will also see decreased glucose and decreased BUN and decreased albumin. In the imaging, you'll see necrosis, which is seen as decreased echogenicity. For hepatotoxins, there's two types, intrinsic and extrinsic. The intrinsic is dose-dependent, such as paracetamol. Extrinsic is phenobarbital. In the case of paracetamol toxicosis, the treatment is N-acetylcysteine, IV fluids, antioxidants, and oxygen. Pathogens for acute liver disease are canine adenovirus 1, leptospirosis, Clostridium piliformis, and Helicobacter canis. Canine adenovirus 1 can cause hepatic necrosis and gallbladder edema. Leptospirosis can cause cholestasis, renal failure, and you treat with doxycycline. Clostridium piliformis can cause hepatic necrosis, and Helicobacter canis can cause hepatic necrosis in young dogs. There are also protozoa pathogens in the case of toxoplasma. It can cause hepatic necrosis and you treat with clindamycin. And parasites can also cause acute liver disease in the case of Diarfilaria immitis. It can cause vena cava syndrome, which can lead to congestion and jaundice. Treatment of acute hepatic failure, you can do supportive care in the case of fluids. You can use crystalloids, colloids, or plasma if there's a coagulopathy. Analgesics, use opioids, do not use NSAIDs. The specific treatments, you can use antiemetics in the case of meropenem or acid suppressants such as omeprazole, or antibiotics. There's a broad spectrum for sepsis. In the case of feline hepatic lipidosis, it's the most common hepatopathy in cats. It occurs in obese cats that aren't eating for a long time, and indoor cats are more susceptible. Types are idiopathic. It can be triggered by fat mobilization, or secondary, it can be linked to cholangiohepatitis, diabetes mellitus, or pancreatitis. Pathogenesis. Anorexia leads to fat mobilization, which then lipid accumulation occurs, and this decreases lipoprotein synthesis. Arginine deficiency can cause impaired ammonia metabolism, which leads to hepatic encephalopathy. In the diagnosis, in the lab test, you'll see increased ALP and increased GGT and increased bilirubin, and you'll see decreased potassium, decreased magnesium, and decreased phosphate. Ammonia will also increase. For the imaging, you'll see hypercholic hepatomegaly. For the cytology, you can use hepatocyte vacuolization, and it can be confirmed with Sudan 3 staining. For treating feline hepatic lipidosis, if it's primary, you need to feed with a nasogastric tube, and you need to monitor refeeding syndrome. You need to give electrolytes and supplement potassium, magnesium, and phosphorus. In the case of hepatic encephalopathy, you can give lactulose, which decreases ammonia, and if there's a coagulopathy, you give vitamin K and plasma if it's severe. For diets, give high-quality food and avoid unnecessary protein restriction, and avoid drugs such as glucocorticoids.